Chapter 25, Suicide and Non-Suicidal Self-Injury. Now, suicide and suicide attempts are major areas of concern in our country. In 2020, 45,979 people died by suicide and 1.2 million people attempted suicide. We will cover suicide and other non-suicidal self-injuries in this chapter. Let's talk about some definitions here. Suicidal ideation, the idea of thinking about killing oneself. Suicide attempt is engaging in a potentially self-injurious behavior with the intention of death. Suicide is the intentional act of killing oneself by any means. And non-suicidal self-injury is intentional damage to your body without conscious suicidal intent and for purposes not socially or culturally sanctioned. So these updates are from 2021. Suicide is the 11th leading cause of death, the second leading cause of death of ages 10 to 14 years, the third leading cause of death in ages 15 to 24 years, and the fifth leading cause of death in ages 35 to 44 years. Now, suicide rates increased 37% between 2000 and 2018, but they decreased 5% between 2018 and 2020, and then in 2021 they returned to a peak. Ask yourself why in 2021. Suicide risk for veterans is 1.5 times higher, with approximately 6,261 deaths in 2019, but this is actually a decrease from previous years. Now, comorbidities, 46% of those who die by suicide also have a diagnosed mental illness, especially depressive disorder, substance use, or psychosis. So risk for suicide. These are individuals with anxiety disorders, personality disorders, eating disorders, or trauma-related disorders, and they're all going to be at increased risk. So loss of relationship, financial instability, and impulsivity also contribute to suicide risk. Suicidal ideation and attempts are common in individuals diagnosed with schizophrenia. Now, genetic risk factors, there can be a familial tendency and it's higher among monozygotic twins. And neurobiologically, these people tend to have low serotonin levels that contribute to a depressed mood, which also increase the risk. Cognitive factors, there are several theories that are used to explain suicide risk. Freud says it's when you turn your aggression inward. Menninger states that there are 3 parts to suicide: hostility, the wish to kill, the wish to be killed, and the wish to die. And then Aaron Beck said that the central emotional factor is hopelessness. Now, there are certain character traits such as perfectionism, rigidity in thinking, and difficulty seeing another person's point of view that can also contribute. Environmentally, these can include family conflict, low parental monitoring, and cluster suicides. And teens are especially at risk for cluster suicides because they're at risk for something called a copycat suicide. So like if a peer or a role model has recently committed suicide, teens are more apt to do it because they're impulsive. Cultural factors can include religious beliefs, family values, sexual orientation, gender identity, and bullying behavior. And social factors can include relationship problems, recent or imminent crises, substance use, health problems, financial problems, legal problems, and loss of housing. Remember, humans are meant to socialize, and our society has caused isolation among people. Table 25.1 on page 474 give you factors contributing to deaths by suicide. You also need to see these bullet points on page 474 for other risk factors, and the box on 25.2 is a very important box. So the application of the nursing process. So SAFE-T is suicide assessment, 5-step evaluation, and triage, which helps identify risk factors, risk level, and interventions. CSSRS is the Columbia Suicide Severity Rating Scale. It is also used to identify risk factors as well as risk level. And then be aware of verbal and nonverbal cues. Patients may make overt statements. These include open messages that are obvious and apparent, like they say, "I'm going to go home and kill myself." But it's those covert statements and those nonverbal cues we need to be aware of. These can include messages with a concealed meaning. An example, "I need to ask Jenny to forgive me for everything I've done. I'm going to give away all of my china when I get home." These are prime examples. You can see other examples here on 475. These are some overt statements, and here are some covert statements. You also need to assess the patient's lethality of the plan, any history of attempts, family history, if they've had a sudden switch from a sad mood to a happy mood, and assess their support system. So talk a minute about the lethality of their plan. For example, running out in front of a semi on a deserted stretch of highway, that means there's little chance of them being helped, means you need to take them seriously. Versus, "I'm going to go home and take 10 Tylenol. Can taking 10 Tylenol cause death in somebody? Possibly. Will it cause liver damage? Absolutely. But if I go home and take 10 Tylenol and tell somebody, there's a chance of me being helped. Versus I'm on that deserted highway and there's no help coming. See your assessment guidelines also on page 476. Here are some more examples of the lethality. It is important to note that asking about suicidal ideations, plan, etc. does not give the individual more of an idea. It actually helps develop a therapeutic relationship and shows that person that somebody cares. And I need you to remember that a history of a previous suicide attempt is a priority risk factor for suicide completion. Now, self-assessment. Healthcare professionals may experience fear, grief, anger, puzzlement, and even condemnation of suicide feelings and intent. So you need to really assess yourself and acknowledge feelings to your team members to avoid counter-transference. Nursing diagnosis, risk for suicide, self-care deficits, impaired sleep, impaired nutritional intake, and anxiety are some of your main ones. But your outcome identification includes suicide self-restraint, and that's going to be key. This table 25.2 on page 477 gives you some of your outcomes. And when planning, be sure to include the patient's support system in their planning process. Now, implementation and evaluation. The goal of nursing interventions when a patient has suicidal ideation is prevention, treatment, and postvention. Primary intervention methods are those that are community-wide and focus on support and education for suicide prevention. And you can find this in the box on page 479. Here's some goals. Question, persuade, refer model helps nurses and other healthcare professionals learn to recognize mental health emergencies and provide the help and support they need. Psychosocial interventions, developing a therapeutic relationship, creating a patient safety plan. These are all important, as well as helping them adhere to a medication regimen. And you can see the figure on page 480 for this as a template. Health teaching and promotion includes prevention efforts. Case management can help identify and maintain support systems, and again, these support systems are critical. Milieu therapy, we haven't talked about this in a while, but remember that milieu is a safe and structured form of group therapy, and that can be important for those at risk for suicide. Your table 25.3 and box 25.4 relate to your milieu therapy. Your documentation must be accurate and ongoing. And suicidal survivors, this is that postvention. Think about all the people affected by the suicide of a loved one. They may experience grief, guilt, loneliness, disbelief, etc. So the support for these people is called postvention. And evaluation is ongoing. Inpatient evaluation and assessment are critical, as well as providing education and those community source resources. So your emergency safety guidelines, when you have a patient that is suicidal, you need to assign a staff member to be with that patient at all times. And you need to check on them every 15 minutes at irregular levels, because believe me, they know when you're checking on them. Ask these patients to share their thoughts, plans, and their suicidal intention. But there's also other environmental concerns. You need to use and count plastic utensils. You need to know how many go in and how many come out. They are not to be given a private room, and that door has to be kept open at all times. You need jump-proof and hang-proof bathrooms. You need to lock doors to non-patient areas. You need to monitor for and remove potentially harmful gifts. In the patient's presence, you need to assess their belongings and search the patient for any harmful objects. This can include something as simple as shoelaces. And you need to ensure that the patients do not bring or leave harmful objects behind. Now, biological treatments, there are pharmacotherapy for comorbid conditions. So those people with like major depressive disorder are treated with antidepressants. Long-term lithium has been effective at reducing suicidal ideations as well. Now, they may be prescribed antipsychotics for psychosis or bipolarism. Anti-anxiety meds may be given. And then esketamine, is a nasal form of ketamine, and it's been approved by the FDA for treatment-resistant depression. These patients may need brain stimulation therapy. So like ECT therapy is useful for patients with depression or psychosis when their behavior is life-threatening. It is also safe for pregnant women or people who have medical conditions that interfere with medication use. And also for those who have not responded to other forms of treatment. Psychological therapies, and again, these are going to be performed by your advanced practice roles. So I kind of want to go back a little bit and let's talk about some risk factors for suicide versus protective factors. So some risk factors could be family history, being male, substance abuse, being schizophrenic, not having a support system, feeling worthless, having access to a lethal mean, and being older than the age of 45. But there are protective factors out there, and those are things like being married, having a good social support system, not having health comorbidities, having mental health support system. So non-suicidal self-injury, known as NSSH, is defined as a self-inflicted act that causes pain or superficial damage, but it is not intended to cause death. Common behaviors can include cutting, burning, skin picking, skin scratching, hitting, and biting. These behaviors cannot be socially sanctioned, such as with a religious ritual. Now, it is difficult to determine etiology because the individual tries to conceal their behaviors. But 15% of adolescents and 17 to 35% of college students will engage in these behaviors. The most common comorbidities include major depressive disorder, anxiety, eating disorders, and substance use disorders. Now, risk factors. Biologically, there are increased levels of stress vulnerability and brain activation in response to negative images. Cognitive, they could see this as a form of self-punishment, and they may have difficulty managing their painful emotions. Environmental factors, adverse events in families like divorce, violence, or parental maltreatment. And societal risk factors can include negative self-worth, isolation, alleviation of personal discomfort, and social media also plays a huge role in this. Now, your nursing process, With the assessment, empathy is important as well as looking for triggers. Ask about traumatic events that may have occurred in the patient's life, and do your self-assessments again because you need to be aware of transference. Nursing diagnosis, your keys are risk for self-mutilation as well as self-mutilation, and our outcomes should include coping, social supports, and adherence. Planning should be a 6-step approach. You need to limit their settings for safety, develop self-esteem, discovery of motive and its role, discovering self-control, replacement with coping skills, and entering a maintenance phase. Implementation, we need to care for their injuries, establish therapeutic alliance, teach coping skills, and promote reflective dialogue. And evaluation, we need to continue to evaluate the patient's communication and their perception. Biological treatments, you treat the comorbidities. So you're treating things like with antidepressants, anti-anxiety medications, or maybe antipsychotics. Psychological therapies can be CBT, DBT, and group therapy, as well as educating on coping mechanisms and skill building. A nurse is caring for a client who states, "I plan to commit suicide." Which of the following assessments should the nurse identify as the priority? B. You need to know the lethality of the method and the availability of the means.